Hey guys, welcome to this discussion. We're going to talk about Cushing syndrome and I'm going to compare this with Cushing disease as well. But first we will look at some baseline information. You see, the issue is that cortisol values in our body keep on fluctuating all through the day. You very well know the fact that cortisol is the stress hormone in our body and the values will rise every time there's any kind of physical or mental stress. The lowest values of cortisol occur in our body when we are sleeping. On the other hand, let me say when you wake up at 6 a.m. in the morning and you're getting ready for your college, or I am getting ready for my clinic, or any individual, any normal individual is going to his office, that is when the cortisol values will begin to increase. In fact, almost 75% of cortisol produced per day, out of the total amount, 75% that is produced occurs in the early morning hours when we are rushing to our work, because this happens to be the stress hormone in the body. And what I've tried to show from this curve in the figure and what I've hand drawn is that in all of us, cortisol production always exhibits a diurnal variation. It always exhibits a fluctuation in the amount per se. But if a person is suffering from Cushing syndrome, the causes of which I will enumerate before you, the values in the body of this person will always remain elevated all through the day. There will be no diurnal variation per se. So in the red curve as compared to the blue curve, what I've tried to explain to you is a MCQ statement. If the MCQ simply says, what is the earliest manifestation of Cushing syndrome? I'll be describing the clinical profile subsequently. That you very well know. Person will become very chubby, very fat, lemon on sticks appearance. You would be having striae on the abdomen, gynecomastia. You all know that, and I'll explain them also. The point is, from the MCQ domain, if he says what is the earliest presentation of Cushing syndrome, your answer would be simple, straightforward: loss of diurnal variation. Now, I could have avoided writing it. I could have just put a cross over it to say diurnal variation would be lost, but I always prefer to do the hard work of writing it, and I would suggest you to also note down whenever I teach you an MCQ, because it's always a good idea, because you are having printed notes, so there's a possibility that you're listening to me but you may not remember the information. So the message is, loss of diurnal variation of cortisol production is one of the earliest manifestations that would be occurring in this patient. And now I will be explaining to you why is this going to happen, and the first and the foremost reason behind development of this would be iatrogenic. Yes guys, we as doctors can be responsible for development of Cushing syndrome in our patients. Let me say I have a child who's having minimal chain disease. Now you very well know minimal chain disease is steroid responsive. It has a good prognosis, but some patients of minimal chain disease might be having steroid resistance also. If there is a steroid resistance, you continue increasing the dose of steroids, but still there is no improvement. And if steroids are given on long-term basis, you not only have side effects that you study in orthopedics like avascular necrosis, what you study in ophthalmology as a posterior subcapsular cataract, but iatrogenic steroids is the most common cause in clinical practice for development of the topic that we are studying, which is Cushing syndrome. And in the body of this child or adult, whosoever is taking these steroids on a long-term basis, cortisol values will rise. In fact, at this junction, I want to tell you that lots of time people might be using Ayush system of medicine, Ayurveda, homeopathy, in which also these medicines might be having large amount of steroids. In fact, in these medicines, there is no quantification of how much milligram of steroid is present per tablet. So a person might be taking some kind of health supplements. He might say that I started going to a gym and my coach has prescribed some health supplements. This is an Ayurvedic supplement. It will help me build up muscle. And this guy is taking steroids on a regular basis. So cortisol values will increase. And from the MCQ perspective, what you also need to remember is that if cortisol will increase, then feedback mechanism will come into picture. So the values of ACTH in the body of this person will reduce. And after a few minutes from now, you will realize the importance of why are we discussing regarding ACTH values. Now, the second important cause for this could be ectopic production. Now, every time you read the word ectopic production, it basically means that ACTH in you and me is produced in the pituitary, the anterior pituitary. But in this chap, there is a tumor by the name of carcinoid tumor, which is doing a lot of, I would say, wrong work in a sense that it is causing excess production of ACTH. The function of ACTH production, the responsibility has been given to the pituitary. This tumor is also causing production of ACTH. So the ACTH values will begin to rise tremendously in the body of this person. This is going to cause stimulation of the adrenal gland. Now you very well know the layers of the adrenal gland from physiology are zona glomerulosa, fasciculata, and reticularis. I want to tell you a concept of physiology here that ACTH mainly acts on not the first layer, not the third layer. The main action of ACTH is directly on the second layer of the gland, that is zona fasciculata, and this fasciculata is responsible for production of cortisol. So in this particular case, cortisol values will begin to spike, but you can know the difference for point number 1 is that ACTH values would be elevated. Now, why that is important to know ACTH is elevated, ACTH value is lesser, is because ACTH actually in our body, listen to this with care, ACTH in our body can have a partial MSH like action. When I say melanocyte stimulating hormone like action, it means the fact that if a person is having excess of ACTH in his body, then there could be development of a clinical finding of hyperpigmentation. This hyperpigmentation that I am describing to you, however, will not be present all over the body, but will be mainly present in the creases of the hand. It would be palmar creases, sole creases, even inside the mouth. You know, if the mucosa, the gingiva can turn black, tongue can turn black, axilla skin can turn black. So hyperpigmentation of the palm and the sole creases, because that's very characteristic. We are not talking about hyperpigmentation all over the body. It is specific flexular areas in the body. Flexular area would be like the groin, the axilla, areas around the genitals of this person, and obviously the palmar and the sole creases. Hyperpigmentation will be seen in point number 2, but you are not going to have hyperpigmentation in point number 1, because if somebody is taking steroids from outside, by feedback, the ACTH values will begin to reduce. Let's do it again. Another ectopic source is lung cancer. You very well know that one of the most aggressive lung cancer is called as oat cell cancer. Even this could be causing excess production of ACTH, and excess production of ACTH would contribute to stimulation of the second layer of the gland, overproduction of cortisol. But hyperpigmentation will always be seen in person of carcinoid syndrome and lung cancer, but will not be seen in an individual who's taking steroids. And as I told you, lots of time these people are not even aware of the fact that they're taking steroids. They will simply say, sir, I'm taking some health supplement and there's something wrong with me. My blood sugars are always elevated. I'm becoming plump, I'm becoming fat. So I just thought I should go and see a physician. Now, coming to point number 3 of our discussion, which is again very important, is that my next patient is actually having a tumor in his pituitary. He is having an anterior pituitary adenoma, which is causing excess production of ACTH. Now, this time ACTH is being produced at its natural site in your and my body, anterior pituitary. This person also anterior pituitary, but in excess. Even this will go and act on the adrenal gland. There are 3 layers: glomerulosa, fasciculata, reticularis. It will act on the second layer and will contribute to excess production of cortisol. So hyperpigmentation will be seen even in point number 3. But what is the difference between point number 2, where I said the word ectopic, versus the natural side, that is the pituitary, is the fact that a technical term is incorporated at this particular juncture, and that is called as Cushing disease. What I want you to understand at this particular juncture is Cushing syndrome is the broad discussion that we're having, and one of the causes of Cushing syndrome is Cushing disease. So every time you read the word Cushing syndrome per se and he says what is the most common cause, your answer would be iatrogenic steroids. But suppose he changes the vocabulary and says what is the most common cause of Cushing disease, then I've explained to you, your answer would be given as pituitary adenoma. It looks very simple at the moment, but believe me, at pressure cooker situation, stress time in the exam, people tend to mess up easy questions like these. So I'll repeat it again: Cushing syndrome, steroids. It could be health supplement, gym supplement, whatever, or I'm in a standard case where you are giving Vizolone, prednisolone to the patient. But if he says the word Cushing disease, your answer would always be given as a pituitary adenoma. And lots of time there would be another terminology that will be used by the examiner, because steroids are being given from outside. So he will say, what is the most common exogenous cause? Exogenous means from outside. On the other hand, because pituitary is obviously from our body, he will say what is the most common endogenous cause of Cushing syndrome. I said Cushing syndrome will be written because obviously he will not come out with the word Cushing disease. That will make it easier for you. Endogenous means it's the pituitary. So you need to get used to this vocabulary so that things become relatively easier for you. And for point number 4, it will be relatively easy in a sense that once again I've drawn the adrenal gland. And what I'm saying is, unfortunately, my patient is having a tumor in the second layer of this gland, that is a tumor in zona fasciculata. The broad term that I'm going to use for point number 4 would be that this chap is having adrenal adenoma. This will be causing excess production of cortisol because the function of the second layer is excess production of cortisol, but adrenal adenoma is an autonomous tumor. You see, it does not require ACTH. It will work on its own. This chap is not going to respect physiology. He will say, sir, I will go my way. When I say I will go my way, I will overproduce cortisol, and because of this, again, feedback mechanism will come in picture and ACTH will become less. So you can very well understand from the discussion that I've said before you that in point number 1 and point number 4, ACTH is lesser. Therefore, there will be no hyperpigmentation. But in point number 2 and point number 3, ACTH is increased, whether it be carcinoid syndrome, whether it be lung cancer, whether it be pituitary adenoma, all the causes, 3 of them, I'll mark them again: carcinoid syndrome, carcinoid tumor, oat cell cancer, or pituitary adenoma per se. Every time these words are written, you have to automatically be in a, automatic mode, that your brain has to automatically register, okay man, he's talking about hyperpigmentation of palmar and soul creases, but it would not be found in point number 1, the chap who was taking health supplements or an autonomous tumor of the adrenal gland. Now, once you get this data into place and you remember these terminologies like exogenous cause, endogenous cause, Cushing syndrome versus Cushing disease. Cushing disease is a pituitary problem. We will now focus on what is the common thing between all of these patients. The common thing in all of these patients, in all of them, cortisol is elevated. Cortisol is going through the roof in all of them. So what I'm going to do next would be explain to you aspects related to hypercortisolism. Therefore, the learning for you guys is Cushing syndrome / Cushing disease. What is the common thing between them? The common thing between them would be hypercortisolism. It's cortisol that is spiking. ACTH can be more, it can be lesser depending on the etiology. Once cortisol increases, let's look at what happens. This particular person will become very fat. He will maybe, like people take selfies nowadays in their cell phone. So he will say, sir, look at my photograph from last year or last year, and you notice that he was okay, pretty, I would say any person like you and me. But now he says, doctor, I have simply bloated up. Whenever I post a picture of myself on Facebook or on social media, my friends ask me, is that buddy really you? I mean, you look so unrecognizable. You put on so much of weight. He says, sir, I have tried modifying diet. I've tried to work out in a gym. Nothing works. I feel so tired all the time. And he has like put up 25 kgs in last 1 year. So what you're gonna get in this chap would be a very characteristic moon faces. It's gonna be a lot of fat in the cheek area of this patient. Chubby cheeks is what's gonna come up in this guy. And also you will notice that there would be a lot of fat in the neck area. Like in you and me, we have a face, we have a neck, and then we have a chest. In this, the face will end and the chest will start. Lots of time in Americans, obese Americans, you would have seen very hefty Americans, a lot of fat in the chest area. In these patients, neck circumference will be increased significantly. That this guy, like I can put up a button in my t-shirt collar, right? You can put up a button in your shirt collar. The neck circumference would be so increased that these patients would not be able to, put up a tie or maybe a shirt button collar primarily. And the importance of this increased neck circumference is snoring will be increased, obstructive sleep apnea would be increased. Over and above this, you will notice that the appearance of this patient, if I'm talking about a male patient, I even highlighted in the image that I showed before you, you can very well see it will give an appearance of like gynecomastia. So as a result of it, what I am using as a broad term in this particular case is the word centripetal obesity. There's going to be a lot of tummy fat in this individual, and because this will accumulate very fast, therefore there would be stretch marks on the tummy of this guy. These stretch marks that are seen in Cushing syndrome and are asked in multiple choice question are referred to as striae. Now the point is striae are found even on the tummy of a pregnant lady, but you will notice that striae in a pregnant lady are pink, whereas in Cushing syndrome the striae will be either violet or will be having a purplish discoloration. In fact, the skin in patients of Cushing syndrome tends to become relatively thin. You will also notice that in this thin skin, chances of injury will be relatively more. Even if they get injured a little bit, there's a big bruise that is developing, so there would be easy bruisability and even increased incidence of skin infections, especially fungal skin infections can be present in these patients. This person will also tell you, doctor, I get tired, and you will notice also that he or she says that earlier I was very active, like I stay in a multi-story house. I have made a 3-story building for myself and I could go up and down the stairs without a problem. But now even climbing 5 steps, he says 5 steps is a Herculean task for me. One, because of the fact that the weight is more, and second, you also get in these patients proximal myopathy. There is weakness of muscles around the hip joint. So these people will be having difficulty in sitting in cross-legged position and will also be having difficulty in getting up from the floor. Like if you and me are sitting on a floor, we can get up in a flash, but these people, there's a proximal myopathy present, and this overall appearance of this patient where there's a significant amount of weight gain and presence of centripetal obesity in multiple choice questions can be written as lemon on sticks appearance. The word lemon is for the obesity, is becoming round, no? So lemon. And sticks is because there is muscle wasting. So I said two things. The central part of the body is going to become very big. I mean, in the chest area, it will look as if he's having gynecomastia. The tummy fat will be dramatically increased in this patient. The pants of this person will not fit, but arms and legs will be very, very thin and spindly. So lemon on sticks appearance is one of a easy way to crack a question of Cushing syndrome. And because most of the time this would make it too easy for you to crack the question, I mean, this try aspect that I've highlighted would anyway make it easier for you to comprehend this. You can try over the elbows of the patient, over the breast area of the patient. And apart from this, if he doesn't want to give lemon on sticks appearance, then let us see what are the other features that the examiner will be writing, so that he does not give you the answer in the first line of the MCQ. Because if you will begin the MCQ by saying a guy going to the gym is on regular gym supplements and is now putting on weight and is becoming chubby, he cannot do weights, and lemon on sticks description is given, you will crack the question in the first line. So he'll just try to ensure that you are not able to do that. Therefore, he will talk about a person or a man or a woman coming to you with complaints of weight gain. Now, since the weight gain in these patients will be tremendous, so peripheral resistance in the body will also increase, because if a person becomes obese, the heart will have to do higher work, the peripheral resistance is also increased. So hypertension will occur, and due to hypertension there could be recurrent headaches in this individual. He will say, I get stressed out with my office work. Whenever a person puts on weight, therefore there's a high probability of developing insulin resistance. I mean, obese people anyway have higher chances of development of diabetes mellitus and insulin resistance. So fasting blood sugar of this person would be increased. You see, the point is cortisol itself increases blood sugar. I said two things. One, I said in this individual, because of the weight gain component, there will be insulin resistance, therefore the blood sugar will increase, and even cortisol values itself cause an increase of blood sugar. So no big deal that when you check out the fasting blood sugar of this patient, it may turn out to be more than 126 milligram per cent. This particular person is not having diabetes mellitus, but is having secondary diabetes mellitus. Why I'm saying secondary is because one endocrine disease is contributing to development of another one, that is cortisol, and combination of insulin resistance is causing the sugar values in this chart to spike. So I'm using the word secondary diabetes mellitus. I mean, I've not used this word secondary anywhere else except for the current topic that I'm explaining to you, primarily because in this particular condition there are two primary reasons why the sugar values are rising. And if he says, what will you do for management of this patient to control the blood sugar? Do not answer insulin. Do not answer insulin. Your answer would be given as metformin. Why? Because insulin itself causes weight gain, no? So I'll be more comfortable prescribing metformin to these patients. And point number 4, 5 are anyway highly important. They are important because cortisol not only causes increase of blood sugar, not only contributes to centripetal obesity, muscle wasting, but it can also act on the receptor for aldosterone. The receptor for aldosterone is called as ENaC, epithelial sodium channel. So if you are going to be having activation of epithelial sodium channel, let's see what's going to happen. There will be more salt and more water coming back in the body, and that's another reason why these patients are having hypertension. I said earlier hypertension due to weight gain. Now I'm saying that even the cortisol is stimulating the receptor of aldosterone. ENaC is a receptor of aldosterone, and this hormone is so smart, it can not only stimulate its own receptors but stimulate epithelial sodium channel also. Now next what will happen is that if salt and water will come in excess, there will also be a urinary loss. Listen to my words carefully. There will be a increased urinary loss of potassium and hydrogen. Why? Because I have just made the arrows thicker to tell you that everything is happening in excess. So because of the urinary loss of potassium and hydrogen in these patients, we will be having a development of hypokalemic metabolic alkalosis. Please remember the fact, whenever I say the word hypokalemic metabolic alkalosis, we read about this not only with respect to Cushing syndrome, we not only read it with respect to hyperaldosteronism, but even in Cushing syndrome, there is a hypokalemic metabolic alkalosis, and I have deliberately changed the ink of writing the data here because this is anyway important. Now the next thing is even much more peculiar, because cortisol can stimulate its own receptors. It can stimulate epithelial sodium channel. This fellow is so nasty that it can even stimulate the sex steroid receptors. You very well know sex steroids are like dihydroepiandrosterone. I mean, you read about a hormone, no? Androstenedione released from zona reticularis. This particular hormone can even stimulate the sex steroid receptors, and the problem if sex steroid receptors would be increased would be, especially from the gender being female, that this female will start having increased amount of hair in male distribution pattern. You see, I'm not saying that the woman is having more body hair, I'm saying the woman is having more body hair in male distribution pattern. So this woman might be having a beard hair or might be having a mustache hair, so cosmetic issues will definitely occur. The question will describe a woman who's having hirsutism, she's having weight gain, and androstenedione will also contribute to menstrual abnormalities. So this lady will also be having oligomenorrhea. If you read this information, just this much of information in the box, a lady came to you, she says, sir, I'm putting on weight and I'm having menstrual abnormalities, and she's having mustache hair or beard hair, you definitely will also think in terms of a disorder that is taught to you in even obstetrics, even in gynecology, that is PCOD. I want you to remember the fact that PCOD clinically is much more common than Cushing syndrome. So if you read a question, listen to my words very carefully, in which this much information is given as given in the red box, hirsutism, weight gain, oligomenorrhea, you have to think in terms of PCOD. But suppose to this information in the box I add hypokalemic alkalosis. To this information in the box I add STRI and I add proximal myopathy, then the answer is definitely not PCOD. Then the answer has to be thought in terms of Cushing syndrome. So I mean, I agree to the fact that PCOD would be an answer to large number of questions, but do take care and do give respect to these terms like hypokalemic alkalosis and secondary diabetes mellitus, which could be occurring in these patients. The last clinical manifestation in these patients is, however, I would say MCQ wise relevant from the perspective that only few patients will be having it. Hyperpigmentation, I've explained to you, this is not hyperpigmentation all over, but in palmar creases, sole creases, etc. But this hyperpigmentation will be present in limited number of cases. Who are the cases who gonna hyperpigmentation? Either those who are having carcinoma tumor or lung cancer. Bad news, right? Hyperpigmentation is bad news because it heralds possibility of a cancer. Or it could be a pituitary adenoma, but if a guy is taking gym supplements or if he's having an autonomous cause like adrenal adenoma, hyperpigmentation will not be present. So I've written plus minus here to tell you that this is not a reliable feature for diagnosis because it would not be seen in all cases. But just for the sake of completion here, just for sake of practice here, let's just discuss what are the situations where it will be present. I've said that verbally, but I'm just making you practice here. Either it will be a ectopic ACTH production, or if it is not a ectopic production, then it could be a pituitary adenoma. For pituitary adenoma, I have told you either it will be written as Cushing disease or will be written as endogenous cause. So just to make you practice these terminologies, once again I have written the causes of when would you get hyperpigmentation in patients of Cushing syndrome, and now would be time for workup of these patients. The question will say, what is the screening test to be done for these patients? For the screening test for these patients, the test would be a 24-hour urinary cortisol values. Yes guys, cortisol is elevated in the blood, so is excreted in urine also. So we can check out a 24-hour urine sample of the patient. The total amount of 24-hour urinary cortisol will be increased. We do have the capacity to check for cortisol even in the saliva. So I mean, look at the technology. We can check out cortisol in the urine, we can check out cortisol in the saliva. The values will definitely be elevated as compared to normal individual. But just to give credibility to the diagnosis, what we can do is we can give these patients a tablet of dexamethasone. Now what does this tablet of dexamethasone do is that in a normal individual, if you will give dexamethasone tablet from outside, you're giving steroids from outside, so it will suppress the pituitary. ACTH production can definitely be suppressed, but you cannot suppress lung cancer ever, no? I'll repeat the fact once again. I wrote the term overnight dexamethasone suppression test. Overnight dexamethasone suppression test means that at 10 p.m. in the night, I'll tell this guy, sir, take 0.5 milligram tablet of dexamethasone, and what it will do is, in a normal individual, it will be suppressing the values of ACTH, and if you suppress the values of ACTH, then the morning, let me say at 8 a.m. in the morning, I was checking for urinary cortisol of this patient. I told you, in you and me, values are definitely more in morning hours. In you and me, we have not eaten any dexamethasone tablet, so values will rise in the morning because we are getting ready for our work and stress hormone will be released. But in people in whom you have suppressed the production of ACTH, the urinary cortisol values will be rather on the lower side. So what I'm trying to say is, by downward arrow, I'm not saying it is less than normal. What I'm trying to say is, in a normal individual like you and me, I don't have a pituitary adenoma, I don't have an ectopic source, I'm not taking any supplement, so you can suppress the production of cortisol. But in a person who's having, let me say, lung cancer, or is taking supplements from outside, the values will remain 24/7 elevated. So any of these three can be written: 24-hour urinary cortisol, salivary cortisol, overnight dexamethasone suppression test. Your first answer for screening would be 24-hour urinary cortisol. If he says in the exam, what is the investigational choice for this condition, then listen to my words very carefully. Your answer would not be given as overnight dexamethasone suppression. Your answer would not be given as high dose dexamethasone suppression. Your answer will be given as low dose dexamethasone suppression test. I'll highlight the importance of this also, but at the moment I just want you to get the word right. In MCQ, to trouble you, he will say overnight dexamethasone, low dose dexamethasone suppression, high dose dexamethasone suppression. You will not select high dose. I'll tell you the reason for that also. Your answer would be low dose dexamethasone suppression test. In low dose dexamethasone suppression, what you are gonna do is, you would be giving a 0.5 milligram tablet of dexamethasone to this patient. This would be given 6 hourly. Like in overnight dexamethasone, it was single tablet at night, and I was checking urinary cortisol in morning. Here I'm gonna give it 6 hourly for 2 days, because I would like to be more sure, because you see, I want to suppress let me say endogenous cause, like let me say a pituitary adenoma. I mean, a pituitary adenoma definitely will respond to this dexamethasone suppression, but lung cancer, that's a nasty cancer, carcinoma tumor, that's never ever gonna respond. So low dose dexamethasone helps you be a little more sure. Now, apart from this, we'll be performing imaging in the patient also, and one of the imaging that will anyway be done in these patients will be a CT abdomen. Why I would do a CT abdomen in the patient is to check out for whether there is a tumor in the adrenal gland of these patients, adrenal adenoma, because adrenal adenoma again cannot be suppressed by dexamethasone. You see, because you cannot suppress it, tumor is gonna do its own thing. Pituitary adenoma will respond. Pituitary respects physiology, but adrenal adenoma, I said, is autonomous. It does not respect physiology. So therefore, lots of time in multiple choice questions, adrenal adenoma can also be written as, and terminology is the most important thing in this topic. Adrenal adenoma is also written as ACTH independent Cushing syndrome. Remember, I told you this tumor is autonomous. He is not dependent on ACTH. He will go my way. He will say, I will go my way. So if a tumor is gonna go his own way, he's not gonna respect physiology, he's not gonna take into consideration whatever be the value of ACTH, I'm gonna call it ACTH independent Cushing syndrome. So that's another terminology that you need to remember. What is the cause of ACTH independent Cushing syndrome? It's the adrenal adenoma, and the imaging that we do in this patient would be a CT abdomen. Let's look at another terminology here. This time I'll change the language though. I will say a patient is having a ACTH dependent Cushing syndrome. Now, when I say ACTH dependent Cushing syndrome, it means ACTH will definitely be elevated, and one of the important causes why ACTH was elevated was a pituitary adenoma in a patient. And what imaging would you like to do for a pituitary adenoma? You would like to go in for a MRI head in the patient. I've created 2 more MCQs for you guys. Listen to me with care. If he begins the question by saying what imaging will be required to identify ACTH independent, the thing that has to automatically be deployed in your brain is independent means autonomous tumor. I'm gonna go my way, CT abdomen. If he says the word ACTH dependent, it means he's talking about a pituitary adenoma. He's talking about Cushing disease. He's talking about endogenous cause. That's gonna be an MRI head. So I would like to rate what I have said at this moment as one of the most important thing for this particular topic, which I find goes wrong in the exams. Everything else people remember, 24-hour urinary cortisol, low dose dexamethasone also, because I've highlighted it, people tend to remember. But in the exam, they get confused between words dependent and independent. So you have to remember either one of them. I would personally like you to remember the words that I said. I'm gonna go my way, apni marzi se kaam karega, he's gonna do whatever he feels like. So when I say independent, it's gonna be a adrenal adenoma. I'll do a CT abdomen, obviously, because the adrenal glands are present in the abdomen of the patient only. Apart from this, I definitely can be doing ACTH levels also. I mean, we can check out the plasma ACTH values in these patients, and ACTH values, as I told you, can either be elevated or can be lesser. Reasons have enumerated. I'll say them once again. Conditions where values would be lesser than normal is gonna be iatrogenic steroids, or it's going to be adrenal adenoma, but it will definitely go through the roof if it's going to be a pituitary adenoma in a patient. So these are a couple of tests, combination of which would help you differentiate. Now comes the aspect, and I think that question would definitely be buzzing in your brain at the moment, that sir, you said high dose dexamethasone suppression. So what is high dose dexamethasone suppression test, and more importantly, when are you going to deploy it? Then high dose dexamethasone suppression test means that here I'll be giving 2 milligram tablet. Earlier I was giving 0.5 milligram tablet at bedtime, or 0.5 6 hourly. For overnight it was bedtime, and for low dose it was 6 hourly 0.5. Now it's 2 milligram 6 hourly. I'm gonna give it for 2 days, and the question in your mind would be, I mean, by increasing the dose, what are you trying to achieve? Well, what I'm trying to improve, or what I'm trying to achieve, is simply that I'm trying to increase my accuracy, because you see, when you give a large amount of, a very large amount of dexamethasone from outside, you can suppress a pituitary, but can you ever suppress a lung tumor? No. Can you suppress a carcinoid tumor? Definitely not. So high dose dexamethasone is primarily used to be differentiating, I mean, so that we are more sure about our diagnosis. See, routinely we go in for a low dose dexamethasone suppression test, but if he says this word, how would you differentiate between an ectopic cause versus a pituitary adenoma? Then you will answer that as a high dose dexamethasone. They would not ask you the dosages. All they will ask you is, when do you do a overnight dexamethasone? That is initial in screening, but the first answer for screening is 24-hour urinary cortisol. For confirmation of diagnosis, low dose dexona is more than sufficient. But if I want to go in for etiological diagnosis, if I want to find whether it's a pituitary adenoma versus ectopic cause, then a high dose dexamethasone can definitely be done in these patients. And now we are going to study regarding what are we going to do for management of these patients. So first and foremost would be, what are we gonna do if a person is taking steroids from outside? If he's taking health supplements, I'll obviously ask him to stop. But if he's taking steroids, prednisolone tablets on regular basis under a physician's care, I need to decrease the dosage of steroids initially. Never stop steroids suddenly, guys. I mean, sudden withdrawal of steroids. This is itself an MCQ. If a person is on steroids for long-term basis, sudden withdrawal of steroids can trigger crashing of BP and blood sugar, that is called as Addisonian crisis. So you very well know the fact that steroids should always be tapered, like it's 40 milligram, decrease it to 30, then 20, and gradually you can decrease the dose. So in this case, I can be tapering the dose of steroids. That will be my first answer. And suppose he is taking steroids for an autoimmune condition. Like suppose somebody is taking steroids for autoimmune condition and you taper the steroids, autoimmune condition will worsen. So what you can also use in these patients are alternative immunosuppressive drugs, which are called as steroid sparing agents. I repeat the fact once again, you are giving steroids to somebody for an autoimmune disease. The moment you will stop steroids or decrease the dose of steroids, autoimmune disease will flare up. So what you can do in the patient is go in for steroid sparing agents. Steroid sparing agents are multiple immunomodulatory agents that you study in pharmacology, like azathioprine, mycophenolate, tacrolimus, sirolimus. So I've just mentioned a couple of them here. The bottom line is, never stop steroids suddenly, taper the dose, and if you think autoimmune disease will worsen, think of an alternative strategy to suppress it also. On the other hand, if a person is having a very bad prognosis, he's having a lung cancer, I mean, oat cell cancer anyway, you know, it would have metastasized to distant organs. So this person may not be receptive to chemotherapy. He may not be able to afford it, or he might say, sir, I have 6 months to live. I don't want to take the side effects of chemo. Let me go home and I want to die in my village with my family members. So we respect the feelings of an individual, but yeah, we will try to convince them to go in for chemotherapy. So for oat cell cancer, what are the chemotherapeutic drugs used? Then I think you are aware, even from pharmacology that cisplatin, remember it's nephrotoxic also, cisplatin, irinotecan are two drugs that would be used. However, suppose the person was found to be having a pituitary adenoma. It was an endogenous cause that was determined because ACTH values were high, MRI of the head was showing a pituitary adenoma of a particular size. So we definitely can recommend surgery in this patient. That would be called as transsphenoidal surgery. But suppose in the patient it turns out to be an adrenal adenoma. Now this is very interesting. If a person is having a tumor in the second layer of the gland, that is adrenal adenoma, I definitely can use drugs in this person. So what are the drugs that I can be using in this patient? Well, there are many of them available. One of them that can be asked from the pharmacology perspective is metotane. Another one that can be used is metapyrone. I'm writing the ones which are more liable to be asked in the exam because they're tongue twisting names like aminoglutathione, metapyrone, metotane. Or we can also use ketoconazole for the patient. Yes guys, the antifungal drug ketoconazole can also be used and is relatively easily available as well. But because I would say that ketoconazole per se is more liable to be answered by you in the exam. You guys are intelligent people, examiner knows that you will be able to crack it, so he might actually talk about these drugs like metotane, metapyrone, aminoglutathione. And adrenal adenoma, because I would like to go in for surgery. You see, the definitive treatment for adrenal adenoma is anyway gonna be like, I would like to go in for surgery and get rid of the tumor. But prior to surgery, for medical improvement, he can ask this question. Adrenal adenoma patient will go for surgery. But prior to surgery, I can go in for drugs that will inhibit the production of cortisol from the second layer. The drugs that I've written before you here, guys, they selectively act on the second layer of the gland, which is causing overproduction of cortisol. And therefore, the technical term which I would now like to introduce in this case is called as medical adrenalectomy. In fact, this was the precise question. The question in the exam said what drug or drugs are available for medical adrenalectomy. I've just increased your vocabulary from pharmacological perspective that you need to remember this. And the definitive treatment for adrenal adenoma would anyway be to go in for surgery. Now I'll create a scenario for you. The scenario is like this. Let us assume that a person is having a bilateral adrenal adenoma. Any person having a bilateral adenoma, I'll obviously tell him, sir, you need to go in for surgery. And this tumor is so big that it is also pressing on the adrenal vein, even pressing on the renal vein. It is producing a mass effect also. So I told the patient, sir, because you are having two tumors in both your adrenal glands, both are producing excess of cortisol. So we would like to perform the surgery in you where we will remove both your adrenal glands. The patient, being educated one, says, sir, are you serious? I mean, you're gonna remove my adrenal glands? I mean, I read that these glands are important for my survival. This gland produces hormones that maintain BP. They help in maintenance of blood sugar, sex steroids, and you say you're gonna remove it. So I'm gonna tell him, yeah, don't worry. Medical science is well evolved that we can do this procedure even laparoscopically. He says, okay, doc, I know that technically you are sound, but then what will happen to my blood sugar? What will happen to my blood pressure after you have done this surgery? So I'll tell him that when your surgery is being done, the anesthesiologist will give you a drip of steroids, that is hydrocortisone, and this will ensure that the aldosterone values and the cortisol values in you will be maintained during surgery, so your BP won't crash. He says, okay, sir, that is perfectly fine, but what after it? I mean, IV hydrocortisone is not going to last me entire lifetime. So I'm going to tell him that post-operatively, I will put you up on tablets of hydrocortisone that you have to take for your whole life. He says, sir, I have to take steroids for whole of my life. I said, yeah, you have to take steroids on a long-term basis. Now he says, okay, boss, as you say, and he has agreed for surgery. I have ensured that intraoperatively no complications occurred. Post-operatively no complications occurred, and this guy has now been discharged. When you have discharged this patient home, he will not have any crashing of BP, he will not have any blood sugar crash. Why? Because hydrocortisone is being supplemented. Hydrocortisone has mineralocorticoid activity also. It has a glucocorticoid activity also. So the person is going to do fine. But the problem is you have removed two important glands from the body which control the values of ACTH. You see, in you and me, adrenal glands are like two check mechanisms on ACTH release. Our pituitary releases ACTH, but the control is from the adrenal gland. If you remove adrenal glands from somebody, listen to my words carefully, if you remove adrenal glands from somebody, the check mechanism is gone, and if the check mechanism is gone, the inhibitory control is gone, the ACTH values will begin to spike, and what will they cause? They will cause hyperpigmentation in this patient. That is going to be palmar creases, sole creases, inside the mouth, inside the lips, groin area around the genitals, then axilla of this patient, hyperpigmentation will occur. This entire description that I have put in the box before you, where a person agreed for adrenalectomy, there was no crashing of the BP, there was no crashing of blood sugar because of our good post-operative care, and we told him you have to be compliant with hydrocortisone, but the side effect that is developing in this patient is hyperpigmentation of the specific sites that I've explained to you. This, guys, is technically called as Nelson syndrome. In the MCQ of Nelson syndrome, there are only two things to be remembered. Point number one to be remembered will be, he will tell you what is the cause of Nelson syndrome. He will say pituitary resection, bilateral adrenal removal, and your answer would be what I have highlighted. And second, he might say what is the manifestation of Nelson syndrome. Your answer is not Addisonian crisis. It is the hyperpigmentation of the palmar and the sole creases that I have highlighted before you. So only two details which are to be remembered for this particular part of the slide. But whatever I said with respect to the workup of these patients is definitely important. So do give due respect to these terms like 24-hour urinary cortisol for these patients, low dose Dexona, imaging modalities which are useful for this condition. There is no single imaging modality for this condition because the etiology of this can vary. No, it could be a possibility that there is a tumor in the adrenal gland, it could be a tumor in the pituitary of the patient, so the imaging modality will definitely vary. So listen carefully whatever, or read carefully whatever he is saying. If he is saying the word adrenal adenoma, or he uses the word ACTH independent Cushing syndrome, then answer CT abdomen. If he says dependent movement, he says dependent, it's relatively easier. Most guys are able to answer a MRI head. And over and above these, all these aspects like exogenous cause, endogenous cause are also to be remembered. So terminology matters for this topic. Otherwise, it's a very simple and a straightforward topic, and most guys are able to crack questions on this topic very easily. So thank you so much for hearing me out, guys, and keep the focus on, keep on learning new topics so that you are able to clear the exam. As I say always, I'm going to repeat it, keep hammering, and you would come out with flying colors.